Good morning, everyone. My name is Dario Quattrocchi. I'm an orthopedic surgeon. I hope to meet you in person as soon as possible. Muscle, tendon, and osteoarticular pathologies are the biggest cause of pain, functional limitation, and disability. These diseases affect 10% of the adult population and 50% of people over 60. So they are among the main causes of pain and functional limitation. For 4 years, I've been using Guna Collagen medical devices with great results. So Guna Collagen medical devices are medical devices made from purified swine collagen and ancillary substances of natural origin. So in order to optimize and use these devices correctly, it is important to make as accurate a diagnosis as possible of the pathology responsible for the clinical manifestation. So we orthopedic surgeons are advantaged because we know the anatomy, the surgical access route, the site of the lesions, so we can directly identify the anatomical but also pathological alterations of the affected area responsible for the symptomatology. So it is very important for us to proceed with infiltration in lesional or perilesional site. So we know that with collagen, we do not always solve the entire orthopedic pathology. Nevertheless, I've had great results treating pathologies with initial degenerative lesions or acute injuries. Once the diagnosis has been made, it is important for us to combine appropriate treatments to optimize the results. For example, in some cases, it is important to immobilize the area where the traumatic event occurred. Collagen is a protein organized with linear and parallel fibers. It is the main constituent of the lesional site tissues. So it has been seen histologically that collagen fibers are altered as a result of traumatic events, direct or indirect, or postural defects and aging processes that create lacerations, weakening the tendon or joint capsule. This gives rise to clinical manifestation, pain, and functional limitation. Collagen has the ability, if injected into the peri or intra-lesional site, to stimulate, activate, and maintain the repair and regenerative processes and slow down physiological aging. This in itself is already a result without creating additional tissue damage. The muscle, tendon, and osteoarticular pathologies that can benefit from collagen injection therapy are manifold. So let's start with the shoulder, the most complicated joint. Now, frequently patients complain of pain related to a subacromial conflict. Now, between the shoulder and, in this case, the left, the coracoid and the acromion is the coracoacromial ligament. Now, in this narrow space underneath, there is a sac, a shock-absorbing pad, which is a very important tendon. So the tendon of the supraspinatus muscle inserted on the head of the humerus. So this is where it passes through. Then there are the other tendons, subscapularis, supraspinatus, and the teres minor, which are those so-called tendons plus muscles which constitute the rotator cuff, allowing the movement of the shoulder, remembering then an important muscle, the deltoid. So most patients, even in the absence of pain, complain of reduced strength and a limitation of movement, which may indicate first a manifestation of distress of the supraspinatus related to this impingement or inflammatory state. This may be due to a normal aging process or the result of mechanical or functional stress, a work movement, a repetitive movement over time, or even a sports movement. So these movements only encourage tendon wear and the aging processes. It would be useful to start even at this early stage when the patient does not yet have a real clinical manifestation, to inject the area with collagen in the very specific areas I have mentioned, the coracoacromial arch, where the shoulder pathology started from, and which can extend to other areas and cause ruptures of the supraspinatus tendon. So not only acute, direct or indirect traumas, but also repetitive microtraumas can promote these wear processes, in addition to wear due to a normal aging process. There are then congenital malformations of the acromion, which may be curved or hooked, predisposing to these pathologies. So, as I said, most patients report pain in this area. The semiotics is also helpful for identifying which tendon is affected. Now, as are simple and inexpensive examinations, an ultrasound or X-ray can confirm a suspected diagnosis, after which treatment can begin with traditional drugs, as well as preventive and curative collagen injection therapy. So once the diagnosis has been made, it is important to associate immobilization, ice or an anti-inflammatory, while the collagen stimulates or accelerates the regenerative processes. So in order for us to optimize the use of the product, it is important to know the landmarks so as to be able to direct the needle as close as possible to the lesion. Now, as far as the shoulder is concerned, the landmarks I will show in the videos are the coracoid process and the supra-external angle of the acromion. Now, once these landmarks have been observed, you can direct the needle both into and around the joint. Now, in these pathologies of the shoulder, I always make double association. An infiltration when the patient is seated from the back into the intra-articular site, supraexternal angle landmark of the acromion, 1-2 centimeters down and 1-2 centimeters towards the median plane of the body without forcing the hand into the articular site, following the orientation of both the supraexternal angle of the acromion and the coracoid. Do not force, since the patient would feel pain and you won't be able to access the site. I then extract the needle, not from the skin, but from the capsule. Incline it by 45-50 degrees and enter the subacromial space, thus the extra articular site, pushing as much as possible to get to the anterior part where the supraspinatus is inserted. Then, making the patient lie down or in a supine position, I try to infiltrate again as a landmark. I also feel the coracoid and the joint, or acromion and clavicle, and inject in the space under the coracoid where the supraspinatus passes. I can incline the needle and inject the extra joint part, the long head of the biceps, which is often the site of other traumatic or degenerative pathologies, which are also causes of pain. Again, from the same axis route, tilting the needle without extracting it from the skin, I reach the trochiter to inject the intra and the perilesional sites of the supraspinatus, subject to wear or microlesions and subject to impingement due to the repeated movement or degeneration of the acromion. Now, we know that collagen is effective in the initial stages of insertional lesions of the supraspinatus, all those syndromes of impingement or subacromial conflict, but also in insertional lesions of the subscapularis following a traumatic event, or in the initial tendinitis of the long head of the biceps, which always starts from a conflict with the coracoacromial arch. Now, in the arthritic shoulder pathologies, good results can be achieved in the early stages. So many patients have reported benefits, and another possibility is to combine hyaluronic acid with collagen injection in the extra articular site to accelerate the repair process. So therefore, having identified the cause of the predominantly capsular or articular tendon or isolated pain, I associate intra-articular injection with peri-articular injection using MD shoulder, and sometimes in association MD tissue, both in the intra-articular and peri-articular sites. I have obtained excellent results for the same age, pathology, even though each patient has his or her own pain threshold, with weekly treatments. In some cases, due to logistical difficulties, I have injected once a month, but still with good results. So, targeted injection after making the diagnosis is important, as is the maintenance even afterwards, not only in the acute phase. So 3 to 5 weekly injections are generally sufficient to obtain relief from painful symptoms. Now I continue up to 10 as maintenance. Now the maintenance injections can be monthly, in some cases even up to 1 year, or the treatment cycle can be repeated after a few months, 2 months, 3 months, depending on the clinical manifestation reported by the patient. I noticed that those patients who, in addition to the weekly injections, also followed the maintenance therapy, no longer reported pain. So, in the case of those who stopped the maintenance therapy, however, I saw after 3-4 years a possible resumption of painful symptoms. And following a radiographic and ultrasound check, a worsening of anatomical pathological alterations, the presence of osteophytes, an extension of the lesion then progressed to become more extensive, more evident in ultrasound. So the use of Guna Collagen medical devices, therefore, enables an inexorable process of aging and degeneration to be slowed down. So collagen has also proved satisfactory in tendon muscle lesions of the ankle and foot. Collagen alone is not enough. Once the diagnosis has been made with radiography, ultrasound, possibly in some cases even magnetic resonance imaging, it is important to associate other medical aids and precautions to optimize the repair capacity of collagen. I prefer it to cortisone, which I use in acute painful phases. Now, we know that cortisone has an inflammatory anti-pain action, but it does not only accelerate regenerative processes. On the contrary, it accelerates degenerative processes. So, the most frequent pathologies of the ankle and foot are those resulting from distorting trauma to the ankle. For example, resulting in a first-grade or second-grade destruction of the anterior astragalic peroneal, posterior astralgic peroneal, and calcaneus peroneal. So again, using bone landmarks as the basis with a single axis, by tilting the needle, I can treat the perilesional site, sometimes intralesional, bearing in mind that it may cause a painful reaction to the patient. Knowing the path of the ligaments and also based on acupressure, I distribute the collagen along the calcaneus and peroneal insertion and the peroneal and astragalic insertion. Other pathologies for which I have obtained excellent results are tendinitis, insertion tendinitis of the Achilles tendon, or tendinitis of the anterior tibial or posterior tibial, or even pathologies such as Morton's neuroma or adacosis of metatarsalgia related to direct trauma or microtrauma. For example, abnormal pronator syndromes of the subastralgics put some parts of the foot under severe pressure, the most frequent being anterior metatarsalgia. Now, in these diseases, Guna Collagen medical devices with an intra-articular or peri-articular injection have given good immediate results, as reported by patients who obtained an immediate benefit maintained over time with weekly injection and or monthly maintenance. It is often necessary to combine other anti-inflammatory, anti-bruising therapies, or in some cases of trauma involving ligaments, even immobilization. So, as said, collagen has a stimulating, activating, accelerating and maintaining action of regenerative and repair processes. I have also used collagen in the ankle with intra-articular injections, but in grade 1 lesions. In advanced arthritis, I did not get results with collagen alone, but in association with other devices. So collagen in the peri-articular site, where inflammation is present at the capsular and ligament level, and intra-articular use of hyaluronic acid with the effect of viscosupplementation. Always keeping in mind the differences between patients. Once the diagnosis has been made, I use MD Neural for the Morton neuroma. MD Neural, sometimes in association with MD tissue, in forms of metatarsalgia and overload syndromes. MD tissue in tendonitis. Another frequent pathology is tenosynovitis, all tenosynovitis. Once the clinical diagnosis has been made, confirmed by instrumental diagnosis, digital pressure provides further confirmation of the suspected diagnosis. Forms of peroneal tenosynovitis or plantar fasciitis are frequent, both in patients treated with instrumental methods without benefits or even surgically, worsening their situation. So before opting for surgical treatment, I always recommend proceeding with a conservative treatment. In plantar fasciitis, MD small joints and or MD tissue, and calcaneal spur, I use 20 or 40 mm needles, getting as close as possible to the lesion site. Digital pressure and knowledge of anatomy are essential for targeted infiltration. I have even got results in knee trauma. Pulled muscles, strains of the internal or external collateral ligament, insertional tendinitis, patella or quadricipital tendon, in the goose foot muscles, insertion of the sartorius, gracilis and semitendinous muscles. Now, these can be found both as a result of direct or indirect traumatic events, sports injuries, as in the case of football players and cyclists. So, following the diagnosis, I associate the regenerative therapy with immobilization in mild forms, not in the third or fourth degree patella ligament lesions. So this is what they do in the first or second degree lesions. So the infiltration therapy is so important. This is basically intra but also peri-articular injections. So the landmarks and the digital pressure are important to identify the site of injury. So with a single axis of the needle, I can infiltrate both the proximal and distal insertion of the external collateral ligaments in sprains, or the intermediate part, So the same applies to the internal collateral or distal or even proximal patella insertional tendinopathies, quadriceps tendinitis, or non-extended muscle lesions, especially of the quadriceps with intra and perilesional infiltration. Intervals of 1 or 2 weeks for 5 infiltrations, so 1 infiltration per week. Then we continue with the maintenance therapy. Now, to optimize effectiveness, it is always best to rest the limb to facilitate self-healing processes. Now, as far as meniscal and articular lesions are concerned, I have had brilliant results in the first, but also second degree arthritic forms with relief from symptopathology, but not always a resolution. Now, I have often used intra-articular hyaluronic acid in therapeutic association in the second or third degree, and in the peri-articular or extra-articular forms with Guna Collagen medical devices near the lateral medial compartment. At the external parameniscal level, as the meniscal wall is continuous but also contiguous with the capsule and the ligament. Now, patients have had transient benefits. Maintenance is important. I have also seen benefits in capsular or ligament lesions. So I use MD knee individually or in association with MD tissue. This is what I use in capsular lesions or ligamentous lesions. Now, at the muscle level, I use MD muscle. As for the protocol I use, so we have 1 weekly infiltration for 3 to 5 consecutive weeks. Then, maintenance, especially when the patient no longer uses the brace, recommended in knee disorders. I have also achieved results with Guna Collagen medical devices in the elbow area and forearm muscles. Insertional tendinopathies are frequent. The classic epicondylitis, medial epicondylitis resulting from athletic or work movements and trauma. I associate collagen with rest, immobilization in some cases, and in acute painful phases with anti-inflammatory drugs. Now, using a single axis, tilting the needle, so avoiding repeated injections, identify the site of the lesion with digital pressure and landmarks, I perform an intra and perilesional injection in the epicondyle tendon along the path of the epicondyle extensors. Now, other frequent tendinitis are the insertional tendinitis of the triceps, in tendonitis of the long head of the humeral biceps. In the elbow, if there are no documented ruptures, the inflammation will be helped by collagen, both intra and peri-lesional. Preparing the patient for a possible painful reaction, I always use MD tissue, sometimes MD small joints. Sometimes I use MD neural, 1 per week. Sometimes 2 per week, depending on the intensity of the painful symptomatology, for 5 consecutive weeks. Then maintenance. Now, highly satisfactory results in stenosing tenosynovitis of the hand, in the de Quervain's disease, and in trigger finger. An X-ray and ultrasound is always recommended to confirm diagnosis. In these cases, the pain is resolved after just 1 or 2 injections. Often, no longer operating the trigger thumb in both cases, or tenosynovitis of the thumb extensor and the long adductor in association again with immobilization, rest, and an anti-inflammatory. Now, in patients arriving for consultation with tendonitis, I associate intra-articular carpal radius injection with dorsal axis. Both in adults and the young, the tissues are subjected to stress. So whether in daily movements, in sportsmen, or those who do manual work, the structures are subjected to continuous stress and therefore wear and tear. I also use Guna Collagen medical devices at an anti-degenerative preventive level. I slow down aging, so I try to get my recovered patients used to doing maintenance therapy. Patients need to be told that even if they have no pain, they are getting older. The structures wear out if subjected to stress due to work or sports movements. I use Guna Collagen medical devices in osteoarticular muscle tendon pathologies, whether or not they already have a clinical manifestation in progress, since even if not yet present, they will develop it as a result of the aging process, which may be accelerated by repeated sports or work movements. Many sportsmen and women are forced to reduce or suspend their amateur or competitive activities due to such manifestations of pain and limitation of movement. Guna Collagen medical devices do not give rise to allergic reactions and do not interfere with doping controls. This is something we can do in our own practice, unlike many other procedures which are more expensive. They include other procedures, for example, PRP, the platelet-rich plasma, which I also use. I actually get the same benefits with Guna Collagen medical devices. So in mild, initial, non-advanced, severe and extensive lesions where surgery is required, well, PRP or mesenchymal stromal stem cells from fat may be used. Now, for PRP, there are regulations which must be complied with. So we have to make sure our center or practice can do this. Now, as for mesenchymal stem cells, a hospital facility may be used. Guna Collagen medical devices do not create discomfort for the patient and are also very cost effective. So you can tell the patient that together with other traditional therapies, collagen is an excellent supporter to regenerate, repair and healing processes. Sometimes I associate the use of collagen with oxygen ozone therapy. There is a rationale because collagen acts with mechanical action with endogenous stimulation of collagen in the injured tissue. Oxygen ozone has an anti-inflammatory, anti-pain, decontracting action and acts on the microcirculation, triggering a regenerative cascade. In my opinion, in acute phases, I cannot use oxygen ozone and therefore I use Guna Collagen medical devices. So I optimize and accelerate the pharmacological action of the collagen.